Hi, everyone. In the interest of time, we'll start, but there's going to be more people who will trickle in. I am really happy to have Dr. Erica Nelson with us today as part of our humanitarian research series. So, a bit of background. My name is Vinay Kamplith. I am an assistant professor of pediatrics and emergency medicine at the University of Pennsylvania. And I am also a member of the GMA Executive Committee and co-chair of the Humanitarian Task Force, who has been really leading some research conversations for the last couple of years on different topics around humanitarian research, whether it be ethics, methodology, or giving some examples of research and practice. And this is a talk that I have personally been waiting for a long time. I specifically asked Erica for this talk because this is something that I've wanted to learn a lot about. So I am really excited to introduce my dear friend, Dr. Erica Nelson, who is an emergency medicine physician who conducts research on the use of geospatial methods for public health and humanitarian response. After graduating from Trinity College Dublin with a PhD in International Peace Studies and Development, she worked as a researcher and policy consultant for organizations serving conflict-affected populations in Nepal, Indonesia, the Balkans, Palestine, Ethiopia, and Sudan. She completed her medical training at the University of Washington, residency at the Harvard-affiliated Emergency Medicine residency program, and an MAS in spatial analysis for public health at Johns Hopkins University. Currently, she is a physician within the Division of Global Emergency Medicine, Global Emergency Services and Humanitarian Programs within the Department of Emergency Medicine at Harvard Medical School, and the co-founder of the Harvard Humanitarian Geospatial Analysis Program at the Harvard Humanitarian Initiative. Dr. Nelson is dedicated to the integration of critical geography, decolonization, and conflict sensitivity frameworks, and the use of geospatial methods for health-oriented humanitarian programming and research. She is engaged in mixed methods research regarding, for example, remote sensing and disaster management, gender-based vulnerability in refugee communities, and the ecological impacts of refugee influx in Bangladesh, geospatial variables as they impact pre-hospital care in the Navajo Nation, the Palestinian-Israeli Health Referral Program, and the interaction between climate, conflict, and population health. She has a really exciting talk prepared for us. And in terms of just a few logistics, you're really welcome to turn on your cameras so we can see your faces, but please keep your microphones on mute. If you have questions, you are free to put them into the chat. I will be taking a look at those questions, and we'll have some time at the very end to have some conversation and ask Dr. Nelson some questions. So without further ado, Erica, I will turn it over to you.
Well, thank you, Vinay, for such a delightfully loquacious introduction. I'm sorry I sent you the full paragraph of my bio. I do want to thank everybody at GMA and Vinay, Holly, everybody who has made this happen. I'm really excited to share this with the GMA community and everybody who showed up. So today we'll be talking about geospatial methods in humanitarian settings. So we are going to move ourselves forward. We have a big agenda today, and we will see if we get through all of it. So this is the outline for our discussion. I'm going to talk about why spatial methods, why do we even care? I'll talk about some current humanitarian applications, the things that you are probably privy to already. And then we'll back up a little bit, talk about some of the basics of spatial methods. And then we'll really get into the meat of the thing. We'll talk about spatial analytics and different types. So buffers, spatial autocorrelation, thinking about things like clustering. And then we'll move into modeling. And then we'll touch on network analysis, geo AI, and some spatial optimization. And then we'll talk a little bit about some critical considerations that are really important when we're thinking about data and time space, especially amongst very vulnerable communities within humanitarian settings. So, why spatial methods? Everything happens in time and space. Pattern recognition, spatial pattern recognition is an innate human process. We all do this from the get-go. Visual spatial intuition and reasoning is different than non-visual spatial intuition, and it's often more efficient and it finds new patterns. Also, with spatial methods, we can make sense of very large amounts of data. So here we're seeing an example of terabytes of data, tabular data, pages and pages of data from the Intergovernmental Panel on Climate Change from 2022, where we are able to make some initial inferences about changes in precipitation based upon different simulations of climate change. Now, you and I can do this. We can look at these globes and we can incorporate and really think about and start to synthesize and make questions about and hypothesize with regards to these huge amount of data that we wouldn't be able to do so if it was just tables and tables of data. There's also a huge value add here. So spatial analytics enables the use of spatial information to understand relationships between variables across space and time. It allows us to extract, like I said before, novel information. Spatial statistics provide spatial statistical rigor to some of the things that we are doing. And it also allows us to inform data-driven decision making. Everybody is really familiar now with the Hopkins COVID-19 dashboard. This is really where spatial analytics kind of came to kind of the public knowledge, and it's starting to grow and evolve. But we've all utilized spatial data in one way, shape, or form. And I'm just here to get you all to drink the Kool-Aid and start to incorporate some of these higher level methodologies into your thinking. Become spatial epidemiologists with us. And lastly, humanitarian crises are stochastic. As you all know, with health, the social determinants of health are huge, right? There are so many different variables that influence health. And the same thing is true for humanitarian crises. There are so many things that we have to take into consideration when we're thinking about programming, when we're thinking about the impact on mortality and morbidity. And so here we're seeing so many different variable types, and these can be aligned if we leverage space and time as something to join them. They can speak in conversation with each other if we use space and time to join them. So, what can spatial analytics answer? Some of the basics: where, right? This is something we're all familiar with. Where are displaced peoples going? Where are healthcare facilities active after an earthquake? And then we can think about relatedness. Is there a relationship between, for example, environmental variables and outbreak incidences? What's the relationship between social vulnerability indices like ADI, heat waves, and mortality? This is, I'd say, foundational spatial epidemiology. Everybody is privy to this map. This is the John Snow map from the cholera outbreak in 1854. What is the value add of this map? So here we're seeing, I know that's really small for you folks, but I apologize. Here we're seeing basically deaths from cholera as little tiny dots, and then where the water pumps were in London. And from this spatial visual analysis, or just spatial visual like thinking, the idea evolved that, oh, maybe cholera is not spread through a miasma through the air. Maybe cholera is spread through our water sources. And so this kind of like very basic means of visualizing, of mapping, actually has enhanced our ability to think about and evolve our understanding of things like outbreaks. Now, what else can spatial analytics answer? We can think about change. So introducing the variable of time. So thinking about how does the distribution and severity of conflict-induced mortality change over time? We can also think about predictions. So how will sea level rise affect the city of Boston and its vulnerable residents in a way to create perhaps anticipatory planning? And then some of the more kind of, I would say, sophisticated methodologies, things that I get really excited about, is spatial optimization. So thinking about how can we use historical data to inform effective data-driven decision making. And in this case, we'll talk about malaria programming. So an example of this kind of change analysis. Here we're looking at a spatial temporal cluster analysis of COVID-19 back in 2020. And in this context, we're using a space-time cube to look at clusters of countries that are behaving similarly. We can look at which countries are alike in terms of prevalence, but in this context, we're actually seeing which countries are surging versus which countries have flattened out. So as you can see, these green countries over here, they surged early on, and then their prevalence rates started to flatten out. So thinking about policy, thinking about intervention, thinking about funding, all of these things can be informed by these types of methods. So what is currently being done now? Well, we see a lot of thematic maps, sometimes choropleth maps, and we're seeing a lot of operational dashboards, whether they be static or dynamic. A lot of these things map out things like populations at risk. Sometimes there's early warning and vulnerability analysis. We also see lots of these operational dashboards out there for situational awareness, thinking about health, integration of socio-demographic data, infrastructure, damage assessments. We see things like sectoral activity that's mapped out. And really the idea is this is for emergency coordination. More and more, however, based upon kind of our best practices as a humanitarian community, we are starting to see a lot more community engagement in data collection, in analysis, et cetera, et cetera. So our thematic maps, I'm sure you are all familiar with these types of very static thematic maps. This one is from OCHA in 2024. And here we're seeing the juxtaposition of violence and internally displaced persons, as well as externally displaced persons and refugees in Sudan. And so with this sort of kind of very static mapping, we can start to think about where do we want to place our resources? Where are the populations in need? Where are they going? And where might we want to position ourselves? This is a chloropleth map from what feels like quite a long time ago, 2017, where the darker the color, the more the number of Syrian refugees in Jordan. And again, static map, but it does allow us to start thinking about very easily where do we potentially want to put our resources. Now, dashboards have become the thing. It's the buzzword. Spatially explicit dashboards are everywhere these days. They're starting to evolve. Here we're seeing one that's looking at active healthcare facilities in earthquake-affected Turkey back in 2024. And then sometimes we see ones that actually juxtapose things like resources, the humanitarian ecosystem, and things like outbreaks or NCD prevalence. This is the Emergency Medical Teams Coordination Cell dashboard, which is mapping out not only the kind of native healthcare infrastructure and how it's operating, but also emergency medical teams, where they're operating, what kind of medical teams they are, and also kind of non-communicable disease prevalence rates. So, maps and dashboards. That's largely where we are. From a community engagement standpoint, like I said, we are starting to evolve as a humanitarian community such that we are actually calling in the voices of conflict or crisis affected populations so that they can really identify what actually needs to be done. Back in my day, way back, we actually did this participatory mapping by hand. We whipped out a map. Everybody in the community got around, started mapping things out. But now we have such great technology, things like Ushahidi, things like OpenStreetMap, that really allow the digitization of spatially explicit data by communities. So we have some really great open source options. But let's take a beat. So let's talk about the basics of spatial methods for a minute. I don't want to assume that you've all drank the geospatial Kool-Aid, so we're going to make sure that we are on the same page about what some of these things are. So first off, what is GIS? Y'all have heard this term, Geographic Information Systems. This is actually the stuff. So this is the multi-component environment used to create, manage, analyze, and visualize spatial data. So that's everything from hardware to the data to the software. Now, what I tend to utilize as spatial analysis is really this like rigorous methodology that uses statistics and attempts to quantify observed patterns and explore processes that may have influenced them. So a little bit of a difference there, only a little bit of a pet peeve of mine if people are talking about, oh, a GIS analysis of blah, blah, blah. It's a spatial analysis. Okay, so what is spatial data? Spatial data is anything with a spatial component to it. So it can be environmental data, it could be demographic data, it can be public health data, conflict or potential political indicators. It can be perceptions as long as it is spatially explicit. We can even think about things like social media posts. If there's metadata that allows us to interpolate where those social media posts are coming from. Just as a quick aside, I love this book by Rebecca Solnit. It's kind of a mixed methodology where they juxtapose maps with very disparate, interesting spatial data data. This one is actually looking at monarch butterfly migration routes and areas of the queer environment, queer friendly environments in San Francisco. And they create these narratives around these very disparate kind of types of data and utilizes and leverages space as that mechanism to come to bring them together and to tell a story. So considerations when we're thinking about spatial data, we have to think about the type of spatial data. Are we going to talk about tabular data and then we have to geocode it? Are we thinking about satellite data? Is it remotely sensed data? Are they call directory data? Things that are pinged off of our big antennae? Are they spatial data that we've collected ourselves that's geolocated already? We also have to think about the scale of the data. So to what scale is it aggregated on a spatial temporal level? Is it state-based data? Is it country-based data? Is it community-based data? Is it census tract-based data? And those things are really going to be important when we think about our decisional thresholds. And then same thing for temporal data. What if something is aggregated to a year, a month, a day? How do we make those decisions? We also have to think about representation types, raster versus vector. We'll get into that some other time. You can dig deeper some other time, but those different types of representations allow for different types of analysis. And then we have to think about projections, because anytime you take a sphere and flatten it, you're going to get some kind of distortion of that data, and you have to think about what are the ramifications of that decision. So sources of humanitarian data. There are so many, and I'm going to whip through them. And so you can go back and watch the video and look at them. I can also send some resources to Vinay and we can extract and we can send them out to the GMA team, or you can contact me. But humanitarian specific data is all over the place. OCHA has an excellent repository. It's called the Humanitarian Data Exchange. I highly recommend you check it out. But there's also information from the UNHCR, from the IOM, and again, from places like Humanitarian OpenStreetMaps, which actually utilizes community-oriented data, community-collected data. We also have things like census data in the United States and in many other places. This is open source as well. We have tons of different grid population data sets out there. There's a lot of conflict data out there. There's also a ton of environmental data out there, thinking about agriculture, water, climate, food. FAO is a great one. So really starting to think about what are the layers that I would want to bring in if I am thinking about some kind of humanitarian health research question or some kind of programming that I want to be evidence-based. There's also a lot of open source remotely sensed data. Some of it's commercial, some of it's not commercial, that I recommend you think about looking into, utilize it. And then if you want to collect your own data, there are plenty of tools out there. I have no COI, I don't own, nor do I invest in any of these, but you've got your fee for service things like Esri, Survey123. You've got some open source options like Kobo Toolbox, which you can turn on your geolocator and just get automatically geolocated data. And then there are things like UAVators, excuse me, which basically is a UAV network that can collect remotely sensed data in disaster and humanitarian contexts. So what do we do with all of this data before we analyze it? We put it into a geodatabase. And this geodatabase is like any other database. It allows them all to come together despite what type of format they are, despite what kind of logic and behavioral models you're interested in. These things allow you to join them spatially and then query them accordingly. All right, let's move into the good stuff. Okay, so now that you are all experts in what are spatial analytics and what are spatial data, maybe where do we get some spatial data? Your brains are starting to churn. Let's introduce the next level of this. What am I going to do with my data in order to actually do something statistically rigorous and actually have some outcomes? So the first thing, the most basic thing, is we can think about buffers and spatial autocorrelation. So what do I mean by spatial autocorrelation? Based upon Tobler's first law of geography, everything is related to everything else, right? We're all interconnected, but near things are more related than distant things. This is the first law of geography. And so we are operating from a space of a null hypothesis of zero spatial correlation. And so the question is there any positive spatial correlation or negative spatial correlation that is statistically different than zero spatial correlation? From there, I'm going to introduce two different concepts. So, spatial heterogeneity is the intensity of what I'm seeing equally distributed across the landscape, yay or nay? And then spatial dependence, right? This is the relatedness question. Does the intensity at one location influence the intensity at neighboring locations? So thinking about things like air pollution, right? If I have one sensor here and it's reading out this amount of air pollution and I have multiple others, what's going to be the most correlated? What is the intensity at one going? How is the intensity at one going to influence the intensity at another? So, quickly looking at buffers. So, buffer analysis is very simple, right? We're taking a point and we're creating a certain buffer around that point so we can kind of figure out how far away and what's included within that buffer polygon. So here we're seeing sexually transmitted infection cases and proximity to bus stops in Baltimore way back in the day in 2015. And the point of this project was to think about how do we decide to optimize where we're going to put our next STI clinic. How do we define accessibility in this context, in an urban environment? So on the left-hand side, you are seeing all of the cases, those are little tiny dots, and then a buffer analysis of 200 meters from any bus stop. And then where are those two current STI clinics? On the right-hand side of the screen, you're seeing a little bit more of evolved buffer analysis in which you're seeing in polygons places where we have cases over 200 meters from a bus stop or over half a mile walking from clinic. Just thinking about how we're defining access in this context. And then we're seeing the number of cases. So, like red is the higher number of cases that are outside of those parameters. And the blues are the number of the communities in which the number of cases are lower outside of those parameters. So we can start to think about where we might want to position a third clinic based upon those types of analyses. Now, buffer analysis is actually just like one of the most basic things you can do, but it is a way to think about access to care. The next thing I'm going to talk about is a little bit more, I would say, statistically involved, methodologically involved, and I'm going to whip through it a little bit quickly. But this is a study that I did a long time ago, utilizing some open source data from the Humanitarian Data Exchange, looking at gender-based vulnerability in Rohingya refugees in Bangladesh. So we looked at 3 different data sources, and based upon a literature review, we identified different variables that contribute to gender-based vulnerability in refugees. We took those data, transformed them into a vulnerability index, and then performed a spatial analysis in order to get a spatial understanding of this gender-based vulnerability. So on the right-hand side here, you can just see the raw analysis. This is just the vulnerability index of each refugee community as it is mapped onto our area of study. Red means more vulnerable, blue means less vulnerable. Interesting, sure, not as interesting as some of our cluster analysis. So here we are seeing a local Moran's Eye cluster analysis, and we saw that approximately 30 clusters are highly vulnerable. And once we map them out, we can actually see these clusters here up near Cox's Bazar are some of the most gender-based, most vulnerable based upon gender in the community. And then these down here, right along the border, this is actually where a very well-established refugee community was already. And we're seeing lower levels of gender-based vulnerability in that community. Now, this can actually help us think about where we want to position ourselves. But I actually think that the next component of this analysis is even more interesting. So here we're actually seeing outliers. Where is one community statistically different than its neighbors? And so seeing, we actually see some communities up here in Cox's Bazar where we saw high clusters of vulnerability. We have a couple of communities that seem to be less vulnerable. And so as a researcher, I start to think, why are they less vulnerable? What are they doing well? What can we potentially adopt and change to improve gender-based vulnerability? And then similarly so down here, when we're looking kind of near Katupalang, There are some outliers where those communities have statistically higher levels of gender-based vulnerability. Why is that? What is different about those communities? So these are kind of places where we can dig in and start to figure out what is making those differences. And then we can split it apart. I know not all of you are interested in things like education or WASH or security. Maybe you're all nerdy ED docs like myself. And so you can break these sorts of kind of analyses into subcomponents and really start to address, oh, I'm very interested in gender-based vulnerability, but specifically from a health lens. Where do I need to focus my efforts? And so you can utilize this methodology in order to kind of focus. So we're going to move on to, again, increasingly sophisticated analysis. We're going to look at modeling. So spatial aggression and modeling, we're really looking for an outcome of interest. So thinking about a dependent variable and what variables matter the most across space. How does the relationship between variables X and Y vary geographically? So in some contexts, certain variables are going to be more important than in other contexts. Think about maternal mortality, education, poverty, access to vaccinations, et cetera, et cetera. Those things, they're all going to be important, but they might be differently important between communities. And we need to understand that if we're going to go and do good work. We're also going to, we could also ask the question of like, what are the factors behind the spatial patterns we are seeing? And like other kind of regression methodologies, these have potentially predictive value. For the nerds out there, there's our lovely GWR equation. I'm not going to belabor it so that we can move on and talk about some examples. So in this study by Seyfu et al. In 2024, they looked at geographic variation in hotspots of stunting among under 5 children in Ethiopia. And then they did a geographically weighted regression model and a multi-level robust Poisson regression analysis to figure out what are the variables that are influencing stunting across the area of study. This is a very busy slide, and I'm not going to go through all of it, but this just outlines the methodology they used. So they had a bunch of data from Ethiopian Demographic and Health Survey in 2019. They looked at the outcome stunting as binary, and then they looked at a whole host of different potential kind of explanatory variables, such as maternal age, education, birth order, place of delivery, et cetera, et cetera. They then did a modified Poisson regression model, which I won't go into. And then they went into a spatial analytical kind of methodology that both looked at clustering, but then also applied a geographically weighted regression model. Now, this geographically weighted regression model actually significantly improved the power of their model by 12%. So here we're actually seeing two different outcome maps. On the left-hand side, we are seeing the proportion of mothers who had no formal education as a predictor of stunting among U5 children in Ethiopia. And on the right-hand side, we're actually seeing the influence of poverty on stunting across the area of study. And as we can see, there are places, so up here near Deir Dawa, where maternal education seems to be pretty significantly associated with stunting, as opposed to on this lower kind of graphic, this lower map here, where we're seeing this kind of line north to south across Tigray, where poverty seems to be much more influential. And so, if we're going to really dig in and be sophisticated about how we influence health in these contexts, we can start to utilize these methodologies to really dig into that information. Lastly, I'm going to move into some network analysis, GeoAI, buzzwords of the day, and then spatial optimization. So for network analysis, the question is, you can do a couple of different things. You can do point-to-point analysis. So what's the most optimal route? You folks are very familiar with this. For me, most earlier today was what is the fastest route to one of my favorite coffee shops? You can find coverage, so drive time analysis, which houses are within 10 minutes of a fire station, like what census tracts are within X amount of time to a healthcare center or an EMT. You can think about fleet optimization for those of you who are interested in kind of transportation, pre-hospital care, thinking about minimizing operational costs. And then you can think about location allocation. So thinking about where do we want to put sites? So, for example, where should we build hospitals depending upon existing sites and demand? And this, I bring you to one of my favorite articles by Garber et al. In 2020, looking at a protracted fragile environment, which is Yemen, and thinking about access to different types of healthcare based upon this conceptual model that integrates healthcare facilities and the types of healthcare they are capable of providing, overlaying that with population data, where are people actually living, overlaying that with road network information, both from open sources, but also satellite imagery, thinking about elevation data, because obviously it's harder to walk up a hill that's really tall as opposed to a flat one, and then thinking about conflict data. It is hard to cross lines of conflict when you're trying to get to a hospital. You can't cross certain barriers, right? And so they incorporated all of these into a conceptual model that thinks about access to healthcare at different levels. And then they did this extraordinary kind of network analysis where they thought about the shortest path. So the shortest path for them was from home, walking to a road, and then from that road, driving to another node on that road that is closest to the healthcare facility that you can get, and then walking to that healthcare facility. And they joined these all together, and then they stratified them into, does it take less than 30 minutes to get there? Does it take less than 60, 2 hours, 4 hours, or over 4 hours? And they did this exceptional evaluation across multiple different types of healthcare. So we're thinking about antenatal health, malnutrition treatment, immunizations, BMONC, emergency surgery. And they categorize them, like I said, based upon different travel times. And so they've got excellent tables, but why am I showing you tables if I can just show you maps? See, we're seeing a really like that table, great. I can go down, I can look at what percentage, but here I'm seeing, oh my goodness. So if I'm interested in healthcare facilities offering antenatal care and the population that is able to access those within less than 2 hours, I look at that map on the left-hand side and I can draw very strong conclusions. This is a very persuasive map. And it's also really useful when you're thinking about, let's say, for example, if you are talking to the Ministry of Health, or if you're thinking about engaging with a humanitarian ecosystem to help support kind of supplemental services. Where do I want to put those services? And then they did this across all of these different types of healthcare offerings. Spatial methods and predictive spatial modeling can also be utilized to think about vulnerability and to think about what may happen in the future. Now, I kind of alluded to this way at the top of this discussion, but here we're seeing actually a vulnerability analysis of Boston. So this is from Climate Ready Boston, where it takes predictive analytics of sea level rise over time and it maps it onto social vulnerability indices. So we can start to see where are the most vulnerable folks going to be impacted by anticipated risks, anticipated threats. And so that way we can start to think through things like resilience, disaster preparedness. Where do we want our kind of evacuation services to be? If we're thinking about heat crises, like where do we want our cooling centers to be? Who are the most vulnerable? Who are going to be the ones that are most impacted? And how do we pre-position ourselves in an anticipatory way in order to be more impactful? The next and the last example I'm going to provide to you is from the global health world, and it's so exciting, but it is also very complex and something that I hope that we work forward towards as both a research community, but also as a programmatic community. In this context, Scott et al. Basically studied how we can use historical data that looks at different types of malaria interventions, juxtapose that with population weighted incidences and epidemiological models in order to optimize our cost effectiveness and impact on malaria programming in the community. So, in this context, they looked at 7 different types of interventions, how they performed historically across different communities, and then, like I said, brought that together with epidemiological models that anticipated kind of the epidemiological kind of trend across time and space, and then created this like really beautiful spatial optimization in which they could say, okay, so I want you to spend X amount of money on something like bed net treatments in this community, or I want you to spend Y amount of money on chemoprophylaxis or on treatment or on education in these other communities. It means to optimize the government funding. In this context, it was government funding, so that you can decrease the morbidity and mortality of malaria in your community. And so, based upon this analysis, they basically said if you use this methodology, if you use these outcomes to change your programming, we anticipate, and again, they need to validate this information, it's still ongoing. We anticipate that you could actually avert 83,000 deaths and 15.7 million cases. If you just take the money that you have already allocated to this looking forward and spend it differently based upon these methods. And so we're seeing a lot of this like really excellent, really exciting literature come out. We're seeing some allocation location things with regards to where do we put blood? How do we kind of pre-position our emergency medical teams? Things like this to be able to be better cost effective, which are big and important buzzwords these days, but also to be more impactful. This is a hard beat for me because we need to take a moment and think about some of the critical considerations of spatial methodologies in the humanitarian setting. I feel like it would be unethical for me to just espouse how extraordinary and how much value add it had without actually talking about some of the limitations. So, certainly, data availability, quality, and interoperability is tricky. There's a lot of work going into data readiness, into interoperability these days. There's a ton of data out there, but we need to think about the limitations of those things. We also have to think about what quantitative data can't do. I'm still very of the mind that mixed methodologies are key, but we are not all of that. We also have to think about resources and capacities, not only of ourselves, but also our computing systems and also of other stakeholders that are a part of this process. Really importantly, we have to think about ethics and decolonization. We need to think about who owns these data. How do we define privacy and protection? How do we aggregate so that we're not calling out an already vulnerable population and making them more vulnerable? We need to think about what does it mean to get consent in these environments. You have to be careful about humanitarianism as neocolonialization and data capture and research as neocolonialization. We also have to think about DEI. I know I'm not supposed to talk about that, but who is involved in this conversation? Who is providing data? Who is thinking about conceptual models? Because that's going to reflect back all of our implicit and explicit biases. And then again, we have to think about problematic conceptual models and the exclusion of local knowledge and expertise. We have to do this from inception of our work, of our research, of our programming. And we also have to think about critical cartography, because as much as I love a map, these are not empirical realities. Every map is subjective. Like I said before, all of your considerations around which data, who's speaking, what types of indicators, how are we measuring them, how are we projecting them, how are we aggregating them, how are we analyzing them, how are we visualizing them. All of these choices can lead to different maps and can lead to different narratives. So we all need to be versed in how to think about maps, how to be critical about maps, and how to discuss maps and not take them just as a priori knowledge. And then we also have to really think about this data to impact gap. I love me a piece of research just for research, but at the end of the day, I think everybody here is really about impact and making sure that we decrease morbidity and mortality amongst the communities that we are working for. And so, what are the things that we need to think about? We need to think about oftentimes there's a lack of spatial literacy amongst these communities. They don't know what maps are really representing, they don't know how to interpret them. Sometimes giving them something as fancy as a GeoAI like data product is not the right answer because there's not, you need to think about how they're going to interpret it, how our whole community is going to interpret it. We have to emphasize translational research. We have to think about political will. We'll stop there. And then we have to think about bringing together disparate communities, right? We're talking about interdisciplinarianism. We're thinking about academia, programming, policy, funding, bring together all of these folks in order to move from beautiful research and publications into reality, into impacting the communities that we want to impact. So at the end of the day, why spatial methods? Like I said, it allows us to understand new patterns. It allows us to extract novel information. It provides statistical rigor if we do it correctly, right? We're all here for a good evidence base. And then hopefully we can take all of that and it can inform more data driven, cost effective decision making, something that is abjectly critical in this current time space within the humanitarian world. So hopefully I've made you drink the Kool-Aid that maps plus math means better insights and better programming. And with that, I'm going to thank you. So I hope you guys get my pun. We're just a bunch of phone guys. Mwah, mwah. Please feel free to reach out to me if you want to have another conversation, if you want to collaborate, if you want to talk methods, any of those things. Like I said, I whipped through a ton, but absolutely happy to be in conversation with you all.
Thank you, Dr. Nelson. If you have a question, feel free to include in the chat. You can also feel free to turn on your camera, unmute yourself, and ask it in person. One question that I wanted to start out with was really with this spatial optimization, which actually that was what I found very fascinating. In terms of all of the different inputs, in terms of how you actually develop a model, how do you decide what goes into the model and how they are weighted to kind of develop your outputs? I'm curious about that.
Well, let's start off with what is the question, right? So in this context, it was how do I make more effective how do I make more cost effective programming to decrease morbidity and mortality? So, right in that context, you have basically two outcomes that you want to optimize, right? Cost effectiveness and impact. So those are your two outcomes. And then you have to think about what'll go into those incomes. So in this context, we're thinking about what is malaria going to do over time space, right? So you have to think about historical data and then your epidemiological model that goes into that. So how is it going to spread over time, over your time period? And then you have to think about, okay, what kind of things do I need to know when I'm thinking about cost effectiveness and impact? So historically speaking, in this context, they had 7 different interventions and they had historical data around what is the impact on mortality and morbidity that's granular to state, and then how much of those things cost. And so, yes, those things will change moving forward, but it takes those historical data and inputs them and allows you, and basically the stochastic descent algorithm puts them into the model and says, okay, if we're optimizing for cost effectiveness and impact based upon morbidity and mortality, if these historical data plus this epidemiological data interact with each other, how do we optimize around that? So it depends upon what you're asking and your conceptual model around like what is going to influence that. So in this context, one of the things they didn't include is they didn't include climate change models, right? So I would say that is a limitation of the piece and something that can be evolved further. So it really depends upon what you have available to you and like really thinking through what are the outcomes I'm trying to optimize and what are the things that influence it. Does that make sense?
It totally does. I think going also to the example in Yemen, thinking about access, I was also thinking about, well, I think some of those inputs made a lot of sense, but I would have never thought about elevation and other inputs
Yeah,
as to what will actually impact someone's ability to access care. I do. It is interesting to think about how data is mapped in a three-dimensional, like real world, and what actually goes into our environment to actually like then affect our decision making. It's a whole different way of
yeah,
thinking.
agreed. And the Garber paper is one that I think is really incredible, but also thinking through like what are the limitations of that? How do we, as physicians, humanitarians, whatever, define access to care on a spatial temporal level, right? I recently did an analysis of access to care and looking at urgent care facilities. But and so we looked at distance, we looked at drive time, we looked at traffic, we looked at social vulnerability indices, well, ADI. But one of the things that came back at us is, well, we didn't necessarily look at time of day. So if someone can't get away from their job in like, and the urgent care is only open from 9 to 5, that means that no matter how close they are, they can't access that urgent care, right? And so you have to like really create a robust conceptual model and be able to justify it. It's never going to be complete, but I think that we are in process as a community.
That's really great. I really appreciate that. And it's getting me thinking about some of my own work that I'm interested in doing. Is there anyone else who had some thoughts or questions that they wanted to lob over to Dr. Nelson?
Again, certainly happy to take this conversation offline or e-meet folks in the future. The short answer is this is a really underutilized technology. This is a really nascent field. So, spatial epidemiology, explicitly in the context of the humanitarian world, is really nascent, and we could do a lot of trouble together. And so, I'd love, love, love to people to reach out to me. There's a lot of research to be done. There's a lot of data out there to mine, and I think there's a lot of impact we can make.
Well, if there aren't any specific questions for Erica, I will close this conversation. Thank you so, so, so much. I think you've gotten a lot of people thinking. I agree that this is an underused methodology. I think it's something that seems like quite a lot and quite challenging, but I think it is something that actually could be at our fingertips and could actually really enhance real world policymaking and like healthcare delivery, which you've kind of demonstrated, particularly with the last example from Nigeria and malaria. So I'm really grateful for you being here today. And thank you to everyone. If you are interested in these kind of conversations, you're welcome to join the Global Emergency Medicine Academy. You can join it through SAEM or the Society for Academic Emergency Medicine. I'll put the website and our link in the chat. You can click join, and then we'd love to have you at our next meeting for both GMA and the Humanitarian Task Force. So thank you to everyone, and look forward to talking to you later.
Thanks, everyone.